So for our next panel, we are extremely lucky to have with us Elizabeth Jennings from the Venture Atlas Lab. She will give us an inspirational keynote speech. I think this is very timely at that time of the day. So without further ado, I give the floor to you, and please go ahead.
Oh, thank you very much, Sven. So it's 4 o'clock in the afternoon, which is one of the best time slots in the entire day because everyone is a little bit sleepy, but the caffeine's going to start coming together. So I am incredibly honored to be here with you today, and thank you so much for offering just a little bit of your time during this wonderful conference to talk about how great things are going in the world and a little bit of depression. No, I'm just kidding. This is an inspirational talk. You know, as you can tell from my heavy accent, I come to you from the United States, and this is a very interesting place to be right now, especially because I work exclusively internationally in supporting international healthcare companies and VC in expanding their portfolio to new markets. So I have been at the forefront of everything, answering all the questions, trying to figure out risk strategy, commercial strategy, uncertainty strategy. How do we fund things? How do we look at the future? Day in, day out, planning high-risk, high-stakes scenarios. I have heard all of the concerns, the quiet ones, the unspoken ones, the ones they tell you after they've had a few drinks at a conference. I have heard all of them from the American side. It is a very interesting intersection. So when I was asked to give an inspirational note, I had to put down my news app and stop reading the news for a minute and think, what is actually meaningful in a few minutes to share with all of you? Working internationally, I see a couple of trends. And the truth of the matter is, when we're looking at the future, we're all building it. All of you are incredibly important people, whether you have titles that make your parents proud, or something that your kids aspire to follow in, or just something that is meaningful to you. You are the people who are building the future, and that means that if you are a scientist, a researcher, a physician, a clinician, if you are looking at data management policies, interoperability, you're thinking about the legalese and the ethics, you're looking at the finance, all of those things are saying, I, in my profession, am looking at the future and the world that we want to create and what we can have at the end of it. So you too are likely looking at what is happening? What do we do about it? And this is an incredibly interesting place to find people. You see, in our profession in healthcare, whether you're on the business, academic, policy, research, or care delivery side of the ecosystem, you know, we all come here to do something that is very hard. There are many easier ways to spend your time than healthcare. We have regulatory, we have complex financial reimbursement systems, and at the end of the day, we all know where the cracks are. We all know where the improvements are, which are so easy to fixate on, all the problems, and you throw in layers of uncertainty into the equation, and it gets heavy. How do you continue to move? And I see people have great conferences, great meetings, and then at the end, they kind of just have to pause. What I found is also a common denominator among all of us here in healthcare is that usually there is a personal relationship with this because it is hard. For me, sorry, I'm trying to get Zoom going. Oh, yes. So for me, I almost never existed. This is a picture of me. I'm the little one. And my mother was diagnosed with a rare neglected disease when she was just a tiny baby. It was an autoimmune disease. And she was given a year to live, but she persisted, and she was given 2 years to live, 3 years to live, 4 years to live. She was given a death sentence every couple of years of her entire life. She struggled. She had every medical intervention possible for all of this, but she kept persisting. The interventions continued to work long enough for me to live. She lived 50 years with a disease that was supposed to kill her every 12 months. This, like I said, is an incredibly hard place because the things that you are looking at in the future, you're touching people's lives. You are touching the lives of the practitioners. When you talk about easing their burden and we talk about making things accessible, the data, it means something at the end of the day. It means they can make better decisions. They can touch lives more efficiently, more effectively. We talk about improving access to care, but these are hard. They're nice ideas, they're intangible ideas. But then what do we get at the end of it? How do we know it matters? And this is where I hear these conversations being the proverbial outsider. You know, from my perspective, coming from the US, I think you're doing pretty well. And I come to these conferences and I hear you talk about minutia, but you're doing so good. There's just this uncertainty of how do we know we're doing good? How do we benchmark it? How do we feel that this is making a difference, that our policies are moving in the right direction? You talk if they're fast enough or too slow. Are they overregulated, underregulated? What's the risk? Things are actually getting better, whether we entirely feel like that or not. You see, one of the biggest challenges, especially I think right now in our very unique geopolitical situation, in our very unique climate, all of these things that are worrying us so much as future planners and future builders, it becomes very difficult to know that it matters. All these efforts that you're making matter, and very difficult to know if you're making the right decisions for your team and your countries and your clients along the way. But truthfully, just about everything is getting better. At the end of the day, all of you are doing very difficult things. You should be very proud of yourselves. We can do hard things. We can do hard things even when we don't have all the answers. It's very easy to get what we call analysis paralysis, where you look at all of the risks, you try to note everything, document everything, research everything, think of all of the scenarios, and then something else will happen that no one could have foreseen. And right now we have so many interesting things we've discussed, like AI. Oh, how AI is going to change the world. It doesn't matter what policies you can put in, what guardrails, because there's 2 or 3 levels in the future that none of us can yet imagine, and I am certain of that. We will always be evolving. In 5 years, we will be talking about the next stage, the next plans, the next reports, and continuing to think, how are we going to handle the new problems? What I'd like to challenge you to think about is how innovations come out of uncertainty and darkness when you may not necessarily see it. You may be working with companies that are innovators or spinning out innovations from your universities, or an innovator yourself, or informing the decisions of innovators as they navigate multiple acronyms. You see, there's a company I had the privilege of working with about 7, 8 years ago. I was a client and advisor of mine called Transformative AI, made by one of the most brilliant AI researchers I've ever met, who is Estonian, small world. He worked at CERN, spun this out of his research from Cambridge University. We helped bring it to New York City, got them about $15 million, and it failed because we ran out of runway. It was a very long, long process of figuring out we could predict 4 minutes in advance with 98% certainty a heart attack. But how do you actually make revenue in that? And we tried, we did some pretty good work, but ultimately did not have a financial success. Now Merrick, then, being the brilliant AI researcher that he was, went on to found Clarium, which received, I think it's around $43 million in Series A funding in the last year, including $10.5 million from one of the biggest value-based care institutes in the United States, Kaiser Permanente. Because the findings that we found out of this failed company, Transformative AI, informed how they could actually make money in the revenue cycle and operations in US healthcare with Clarium. And I have hundreds of these cases with innovations that got sat on a shelf, that got hung up in policy, that ran out of money waiting for something to move. And that's really the problem I see, is that there's only ever so much we can do, and then a policymaker changes something, or tariffs come along, or there's so much uncertainty that you can't fundraise enough, or you're fundraising as an investor yourself and your LPs pull back. There's so many interrelated pieces of all of this that when uncertainty comes through, people freeze, and the risk is too much. And maybe that's worse than anything else. So I've been in healthcare for a long time, and this goofball over here on the right was my business partner. He doesn't know I'm playing this video, by the way, because he's in the US. And this is another colleague of mine at a conference. Now, I had the good privilege of working with him for about 10 years in my company. He was a senior vice president at Siemens. It's a big organization you may have heard of from Germany. And then he was the CEO of Toshiba, which spun out into Canon several years after he was the first non-Japanese CEO. We were standing around at one of these conferences one day, and he says, "So wait, how did your mother die?" Now, of course, this is a tragic thing and something that obviously led me to wonder a lot about healthcare. How could we have made this better? Such a neglected disease, why was it neglected? And then all the people who helped her along the way. And I said, well, actually the disease didn't kill my mother. She started getting pneumonia as a byproduct of her illness. Her lungs were filling up with fluid. And so one day she was rushed to the emergency room and they did a tracheotomy. And they put in a breathing tube and a breathing machine to help her along the way. It was, a fairly easy procedure. And a man who was operating the breathing machine accidentally hit the wrong button, and she suffocated and died. There was a long pause as he looked at me and said, "Have you ever considered that she was murdered?" Well, no, who would kill my mom? And of course, I was a child when it happened. And I said, well, why would you even suggest such a thing? And he said, well, we were the people who made those machines. And we thought about that. We thought about how to make a medical device safer. We thought about accidents. And this is where healthcare gets messy. We look at things in clean frameworks, policy, research, denoting how to do things in principle frameworks. I know that, I'm a consultant. Don't hold that against me, though. We think about these things, and then the real world, something that we never could have predicted happens. And I look at this knowing that forever in my life, I will never know, it will always remain uncertain, whether that man's intentions were to murder my mom because he was a sociopath, or it was an accident. It will always be uncertain. And to me, so much of what I see in the world right now is very similar. It's the same when we think about everything. So much is uncertain, and you can't interpret uncertainty. It simply is. It's a state of quantum lack of witness. And we wait while we gather information. We continue on. This is what it's like to actually deliver the care. When you start working with patients, when you start looking at service lines, when you put something into operation, sometimes you don't know, and you have to move forward through that nuance, through that uncertainty, and not say, this is too much to move forward with. Now, I mentioned this story to you because I know it's not necessarily inspiring to say, hey, maybe my mom was murdered. Because so many people will look at uncertainty. They'll look at the stock markets. They'll look at what people say in the news. They'll look at different projections from different companies and say, okay, I'm just going to wait and see. I'm not going to go right now, or this is over. They'll draw conclusions, and they always draw the most negative conclusions possible. It's the most amazing, remarkable survival instinct of our lizard brains. But yet that's not true. It's uncertain. It's not yet determined. It's not yet written. When you look at patient information, you're looking at all of these different trajectories, you know that you can't make foregone conclusions before you have all of the information. And even then, you caveat it with, well, this is what we see based on this. You don't draw conclusions unfounded. Now, I don't know what happens in the world. I don't know what happens next. I don't know what happens in my country, your countries, our relationships. I don't know what happens in data and interoperability. The things that you're looking at with the AI Act, we are too. And of course, my job is to make your company successful elsewhere, in addition to however else I can help. And there's so many different moving pieces. So the interesting thing for me is not to know all the answers. It's not to reduce the uncertainty. It's not to tell you that, no, things are concrete and we can at least navigate around it. Instead, I just know what I'm going to do about it. What I would like to encourage you to do is not wait and see, not draw conclusions that aren't certain when you find that perhaps one or two men have their finger on a switch and we don't yet know their intentions. We don't yet know what happens. And those may be people in your lives while you're trying to get adoption for your technology. They may be your investors, your colleagues, your policymakers, those who could jeopardize so much of your long, hard work to make things better for your communities, for your patients, for your research, your innovations. It's difficult when you have those situations. And it's difficult to say it's worth the battle. It's worth the political capital. It's worth the persistence. It's worth all the airline miles to come and spend 20 minutes telling you an inspirational message when maybe no one will care. In our line of work, we can wait and see, but we may not know how it actually goes in the end. If you're a furniture maker, you get to see at the end of the day with certainty, I made that chair. But if you're looking at policies, you're looking at research, it usually takes a long time to see the fruits of your labor. And at the end of that, you rarely get to know with absolute certainty the people you helped, your colleagues along the way. You feel little pieces, but you don't really know. So, for me, I decided not to worry about the one man and his uncertain intentions and that unfortunate incident. Because although there was one who was there in that moment, there were 500 people who gave her those 50 years that she had. There were researchers I never met, people in pharmaceutical companies, people who were building new interventions that worked, people who led clinical trials and CROs that helped, doctors and physicians, and so many people along the way who had absolutely no idea that one day I would happen and that I would be able to be here with you in Estonia. You can't draw conclusions that things are uncertain, therefore they are bad. I don't know if my work matters, therefore I give up. It's really interesting working between internationalization and investment because I do often have to be the bearer of bad news, which is that the technology won't scale, it won't get adopted, the finances don't work this way. I'm often actually the bearer of very bad news. But here in this room, this is a very privileged audience. Yet no one is coming to save us. This is it. It's us. We are the champions. We are the people who are making things different. These are the meaningful conversations. If you see something that is not working well, you can solve it. I believe in you. We can do hard things. We can do hard things without all the answers. We're not going to draw foregone conclusions, and we're going to persist through whatever uncertainty we see. If you're a runner, when you run a marathon, you don't stop when it gets hard, you don't stop when it gets tiring. And I think all of you really are career marathoners. You truly know you don't stop when you arrive at the finish line. If things suddenly ended and policies got difficult, relationships got difficult, you don't just stop. You run as fast as you can to get through to the end of the line. You run through the tape. Now, I know things can be challenging with some of your projects when funding changes. I know it's challenging when you have to lead and be accountable for making decisions, maybe with incomplete information. But I encourage you to keep moving forward and doing the very best that you can. It's the only way anything will ever be solved in this world. And even if you don't know, at the end of the day, I absolutely promise you it matters. And I appreciate all your work. If you'd like to contact me for whatever reason, this is my contact information. The QR code is a lot easier. The questions and answers about anything you might want to talk with me about can be done afterwards. Yes, and with no further ado, we will introduce our next panelists. So this is interesting because I mentioned a couple of things just a moment ago around the situation in the world, and it's maybe not actually as bad as it sounds. And trust me, I come from Texas. It's complicated. But there's a lot of persistence through uncertainty. And there's a lot more collaboration when you really get down into what's really happening, who's persisting, who's doing things. You have people who will travel 33,000 kilometers to come see you. Those 33,000 kilometers are added up by my colleagues, if you would like to join me, in traveling here to make all of this innovation better. Nope. Okay. You know, it's actually very tiring to travel 33,000 kilometers. I hope you guys have been to our regions as well, and you know, you don't just decide to do these things for the fame and glory, although that is a nice perk. We are, you know, gloriously caffeinated. People who travel this far come to see what you're working on. They come to listen. And today we are incredibly honored to have with us two very important ecosystems. We have Singapore and Australia. And earlier today, it was a fascinating conversation with the Gulf coasts and all of the collaborations happening in the Middle East. And now I'd like to take a moment to look at two other ecosystems that have decided, you know what, we don't know necessarily everything that's going to happen in the world, but we know what we're going to do anyways, and we're going to hop on a flight and come. I did check, well, ChatGPT told me, so if the math is off, I apologize. But ChatGPT told me it was 33,000 kilometers between the three of us added up. So without further ado, I'd like to introduce our colleagues, and coming all the way from Australia, we have Ms. Melissa Pollard. Could you tell us a bit about yourself?
Certainly, and it was 36 hours travelling time from the time I set foot in Sydney Airport to the time I arrived at my hotel in Tallinn. So first time in Europe, so first time visitor. I've been other places, but I was very, very excited when I received the invite to come. I am the Executive Manager of Digital Health and Technology for my organisation. So I work for an organisation that's a not-for-profit that supports primary care in my region. And if you don't understand, I suppose, the size of Australia, so we have about a population of 28 million people. If you couldn't fit the entire Europe into the geographical footprint of Australia, if you wanted to fly from Sydney to Perth, it's the equivalent of flying from London to Tallinn, then to Athens. I did use ChatGPT for that. But I think Australia is quite a complex structure as well. And if you think, it's a not-for-profit, it's a small not-for-profit. Australia is made up, we have a Commonwealth, so we have a national body, we have a state legislature, or state body as well that supports health. And I support 3 regions, Hunter, New England and Central Coast. Now that's the equivalent of 1.3 million people, same size of Estonia. So part of that is why I'm here. It's about the same size in terms of population. It's got a very much the same diverse kind of structure. So we have very rural, remote areas in metro. And I think there's a lot of opportunity and there's a lot of learnings here. And we have been doing some work with Technopole. I think it's because I think you can't do things yourself and you have to collaborate and partner with others. So it's why I'm here. I think the other thing, if anyone's looked at me on LinkedIn, I did spend 24 years in state government working in health. I am non-clinical, so I'm very much a non-clinical person working in a health system. But I think it's actually, I've spent enough time to understand the complexity of health and understand the barriers that people face in health. But don't ask me a clinical question, anyone in the audience, when we ask questions, because I won't be able to answer it. But I have an IT background.
You know, I love something that you mentioned, which is that we can't do things alone. And I think some organizations try, but they shouldn't. There's so much you learn through listening, and particularly in different systems that naturally incentivize different things. One of the things that I love about the Nordics, the Baltics, and quite frankly, a lot of Europe and Australia, is that you have far more progression around value-based care, which is something that in America we're just now discovering, that if you look at outcomes, it improves patient care. we're a little late to the table, but we have so much to learn from organizations like yours in how you structure those and how you make them useful for the entire population. Now, we also have an incredible person joining us all the way from Singapore. I'm not sure what your flight route was like, but I think both of you are just under 9,000 kilometers in travel distance to get here. So, Smitha, SUNILDEEP, could you tell us a little bit about yourself as well?
So Singapore is just a tiny red dot on the map, and we are only as big as Huma, your second largest island, and but the population in Singapore is 6 million. So about 4 million residents, permanent residents as well as the citizens, and we have expats making up the other approximately 2 million people in the country. So I'm not a data person, but data is core to innovation. And I work at the National Health Innovation Center in Singapore, and we support clinical community by providing funds to help commercialize their ideas into market back to the hospital systems by providing support for implementation. So we have been hearing a lot about Estonian digital health infrastructure, and I was here with my executive director, Henry Ho. He had to leave earlier this morning to attend to a surgery. But we were really here to learn about the digital health infrastructure that you have in place, and it's been an incredible 2 to 3 days of learning. And in Singapore, we have the Estonian Business Center, and I was one of the first visitors, probably the first one when it was inaugurated, and it was so vibrant. The people were vibrant, the conversations were vibrant, the events were vibrant, so it gives me, I'm really happy to be here to, see that enthusiasm in person. Yeah.
Something that I am very interested in hearing from both of you is you've mentioned this digital infrastructure and learning from Estonia, but also having methods of collaborating both on outcomes and on innovation early on in that digital infrastructure. And it's so much of the nature of what we've been discussing today. Melissa, could you tell us a little bit more about how you look at that digital infrastructure from your perspective, and maybe what you've seen a little bit as well as what's naturally well aligned from Estonia?
I will say I'm very jealous of Estonia's X-Road system, because I think in Australia we don't have that same infrastructure. And if I give a context from my old role and my current role is, for example, in New South Wales. So New South Wales Health at one point had 23 separate EMR platforms across their local health districts. Then if you put into context the number of general practices in our state as well, they all have their own individual EMR platform. None of them connect. At a national level, we do have some connections. So we have a solution called My Health Record. And My Health Record is where a lot of your clinical notes from your GP visit and hospital visit is supposed to be uploaded. It is an opt-in method. So it's not always accurate. I know personally, before I came over, I had some tests done. I logged in, thought, yay, I can get on, stick my results in ChatGPT and see what's wrong with me. Just joking. But my results weren't there, because the practice that I saw actually hadn't opted in either. I had opted in as a patient, but the practice hadn't opted in. So the infrastructure in Australia is, it's very good when it works, but it's not consistent. One of the big things that's happening in New South Wales at the moment, particularly in the hospital systems, is that we are implementing what's called a single digital patient record. It's a 3-4 year program. It goes live in my region in March next year, but that will be one EMR system for the state. So that is pretty impressive. And there's about 8 million people within the state of New South Wales. So every patient that enters the hospital system will have, their record will be one record. So we have a lot of, I live in Newcastle, and Sydney is very much, everyone's heard of Sydney, but we do have patients that actually have to go from Newcastle to Sydney for clinical care, and in the past, you would have to redo a lot of the tests. You'd have notes shipped along, but you would have to redo a lot of the tests, a lot of the clinical diagnosis again. This will mean you don't have to do that. Now, the irony of that, as I said, I work in primary care and we have very fragmented systems, and GP systems have all their own, is that the general practice, GPs will not get access to that system unless you work in hospital. So it is quite limiting in terms of what that looks like. We've been advocating for that, and we currently have 4 practices that can participate. And you're probably thinking, why? Legislation. So the legislation in Australia is that you have to have consent. Going back to that national view, you have to have consent for people to have access to your information. And our laws are not set up to support that at the moment. So if you go to a general practice and you have pathology results and you have X-rays or you have MRIs, sometimes it connects if you do it within the hospital system, but if you go through private providers, often that doesn't connect. The results do. We have e-referrals, we have e-prescriptions, but it doesn't all integrate. So that's why I'm very jealous of the X-Road platform and the way that as a person in Estonia or a patient, you can log into a single system and see everything. If I had to, I think there was the question around before, around a dream, that would be a dream for in Australia. And for myself personally, but it is very fragmented. We hear a lot of frustration coming from clinicians, particularly in general practice, because it creates inefficiencies, it creates rework, and it creates challenges. I think it's amazing that New South Wales Health are moving in this direction of a single digital patient record. I mean, as I said, Estonia is 1.3 million, that's 8 million people. That is a really good step in the right direction, but we're still a long way off before I think we can start to see the same infrastructure that you have in Estonia.
You know, it's interesting to me because I think this really goes to that point of you shouldn't do things without listening to others first. And it's really difficult, you know, like in the US, for example, we are famously efficient and good at managing our healthcare, right? World-leading example. Unless, of course, you want good patient outcomes and happy providers and a good financial status. And it's interesting because we're just this big conglomeration of a bunch of different experiments. We have a model of care delivery, every financial model that there is on Earth, somewhere in the US, usually in the same building, all happening at the same time. And we look at regions like Australia and we think, wow, you've really thought some of these things through. And then you hear from Australia, well, actually, we also have some of the same problems. We look at areas like Estonia and I hear different kinds of, oh, the grass is greener over here. We have these challenges. And then it sounds, wow, you are actually you had a lot of willpower to see the future and how you could think, let's just go digital first. Let's all collaborate together. This is more meaningful than perhaps you may realize. And it's very, very difficult to do after the fact because you do have to change so many different policies and so many different gears. The other tragedy is that if we can't fix these things, if we can't begin to collaborate more systematically, so many good innovations are left on the shelf because they just can't be operationalized.
Right.
So in terms of taking all of those innovations and getting them in the field and looking at making meaningful infrastructure, Smitha, I'm curious if you can tell us a little more about how that's working in Singapore.
Yep. So Singapore has invested billions of dollars in early 2000 for R&D. And since then, besides basic, research and development, there was the question that the government asked is, please move towards translation. So we have really good universities, research institutes. We do have good academic medical centers. So the government, in specific, the Medical Research Council, actually put in funding to support clinicians to provide them protected time for research and innovation. And you know that clinician contact, sometimes it's a tech push. But when clinicians come into the picture, not just to provide data, but beyond, that's when we see things really moving. So NHIC was set up in 2014. And we have 3 public healthcare clusters in Singapore, although we are just a dot. And up until 2022, all of them were using different systems. But now the government has pushed out an initiative, and at least 2 clusters are using the same system. And the 3rd cluster is now moving into that transition. So since we started funding innovations coming out from the clinical community, from ideation to commercialization, we realized that a lot of them are just sitting on the shelf. Good IP, but what is it that's required to move that product into the system? And the skill set that you're looking at during the implementation and adoption is very different. And when we looked at our portfolio, it's actually the digital health projects that are in the downstream, like really close to implementation. So we actually introduced a new piece of support as part of our offerings, is to provide funds to pilot innovations across the clusters. So the hospitals were doing their own work, implementing it in their own hospital institution, but the mandate was to actually find a collaborative partner from the other clusters so that we can enable national scaling. So, okay, so now we have the funds, but how do you operationalize it? So as part of our first call, we realized that there are so many aspects that need to change if you want to enable that system-level transformation. It's not just being piloted in one ward. There are so many touch points in the system that require that system-level transformation. So now we are in the 2.0, where we are trying to implement all our learnings in that sense. So, and that requires change management, ops, and we still face challenges in the sense that we don't have the expertise to experts who are busy doing their clinical work to actually work on these aspects that really take a lot of time. So yeah, we have heard about the wonderful innovations in Estonia, and very close to being applied in the real world setting. We are almost there, but we still have some digital infrastructure issues that are currently being resolved. Yeah.
I personally always find this reassuring because in the nature of my work, I'm between helping someone internationalize and helping them get funding to internationalize, which is why I said earlier, usually I'm the person bearing bad news. Do your technologies in Singapore translate to our fax machines?
Sorry,
does your technologies, your interoperability also do all of this infrastructure and then fax it over to America? This is a joke. I'm sorry, I can't help myself.
Sorry, I didn't.
A lot of the technology still is done by carrier pigeon and slate chisels. So, we look at all of these different methods of moving information, and it's not just do we have EMR compatibility, right? It's are we using like information from wearables? There's so much innovation I've seen come from your regions, but does this have data integrity and consistency to be contextualized in a patient case file? Do we have enough longitudinal data from all of these sources to, after you put all of this effort in building that infrastructure, to go back and actually improve patient outcomes, improve service lines, get that real world data to say the next 5 years are going to be measurably better? And these are some things that I've been really impressed with, is that when you start translating the thing from one cluster to another, as Smitha has shared, you start to get more longitudinal data that's properly contextualized to see different specialized regions and different approaches to similar cases where you get unusual and interesting data. Could you tell us, Smitha, a bit more about what's working well there and what you think is maybe something you didn't expect to work as well, but a good positive outcome from this effort of collaboration between clusters?
Yeah, so we do have our healthcare IT system that helps with the integration. And I would say that most of the projects that are currently in the pilot phase are AI-based projects. So some of the challenges that we didn't expect are the heavy expertise as well as financial resources that come with the integration. So that's something that we have now added it as part of our grant monies to help support that. And like I mentioned, it's really those touch points that were not identified at the proposal or the application stage. That means the understanding in terms of the extent of how this should be implemented, we felt that there was a gap. So in the 2.0, we are setting up processes to ensure that the technology owners know what they're getting into. So clinicians are there, they know the systems, but the back-end IT aspects was something that that was missed in the sense, in terms of planning.
That's
the
great.
good thing, and the good thing that came out of it, so all the 3 clusters, they have their own strengths and weaknesses, but they will not admit it. It brought them together to work. So we have over 10 projects where we have more than 2 clusters working together. So the collaboration, the competitiveness, competition is good, but when it comes to national scaling, the cooperation, the openness, and the transparency, they're very important. So we're getting there in that sense.
That's a really interesting balance that you just mentioned, the cooperating but still competing, which is, of course, a really big challenge in the US because we could have more interoperability and transparency between systems, but they like to make sure we don't do a good job at it, so it's all a secret. I have seen some very impressive examples of meaningful collaboration between different regions and institutes out of Australia. There's some efforts I've seen in funding schemes and in programmatic efforts from the federal level in Australia to not just go to standards and standards of care that can be changed across regions in different care settings, because of course so much of Australia is starkly divided between rural and urban, deeply rural and deeply urban. I'm very curious, Melissa, if you can share more about how you've seen policies that you've worked at. You have such a wonderful background between having seen these things interacted from a government level down to reality in a care setting, and now on the other side as well. What's working well in making something that can work in your region as an example for others in Australia?
It's a really good question. I think that at the moment, and I'm having a mental blank of what it's called, but I think one of the best things that we are is that we're looking at the fire standard and how that's implemented. Policy's still not quite there yet, but there is a lot of work happening at a national level around that integration. They're bringing it together, so at a Commonwealth national level, at a state level, they're bringing in private organisations, and there's a number of different working groups and standards in terms of how you bring that together, how we implement it, what that looks like. The policy is still not quite there, and I think that's where there is work underway, and starting to think about them mandating that if you are building a system that you have to have fire as a standard. So that's where I've seen it work quite well. And as I said, it's still underway, but the vendors are starting to see that that's coming. So they're starting to make that change. So I think that's an example. I'm trying to think sort of, one of the things that I suppose it's not it's a bad example, is if I think about AI. We don't have AI legislation in Australia. We have a number of other legislations that touch on it. If you think about a Venn diagram, kind of sit around the surface, but we don't have specific AI legislation. It's coming. And I think you will hear that it's coming. That there's a lot of things in development, but we're a little behind the 8 ball. I don't know if anyone knows what that saying means, but we're a little bit behind everyone else. We do have really strict rules around from the Therapeutic Goods Authority that govern software as a medical device. So we do have some structure. But as a country, we don't have AI legislation, and I think. For me, I was on the New South Wales Health AI Task Force, and one of the other government agencies built this beautiful AI framework. It didn't have specific requirements for healthcare. So it's one of those things that sometimes there is a little bit of a disconnect. The framework itself, if you're in a corporate role, if you're in organisation, education, transport, any of those government agencies, it fit perfectly. But in healthcare, it didn't cover specific needs in healthcare. So I think there's some really good things we're trying to do, but we're just not there yet, and there's still a little bit more work to happen. But I think in a few years that we'll hopefully not years, but hopefully we will soon, start to see some change, because one of the things I see in my current role is, as I said, it's in primary care. We have a lot of overseas vendors coming to Australia and saying, I have this great solution. I've seen some from Singapore, we've actually seen some from Estonia, we've seen some from the US. And one of the things is when you come in, we have very strict laws around data protection. And I think that is the one thing that does work very well. And if you have health data, we have the sovereignty law. Everything has to be kept on Australian soil. And when you start to think about AI, that's one of the biggest barriers as well. Mm-hmm. So you can have the most amazing solution, but if you do not have the infrastructure on Australian soil, then you can't use it, particularly in health. So I actually am very comfortable with that as a citizen, as a patient, and so I think that works well, but the rest of the structure around everything else is still under development.
Yeah, this is something I appreciate a lot, because I think most of us in our daily lives are so focused on the micro problems of our ecosystems and infrastructures and cohort of projects we're working on that we don't recognize we all really face the same problems in different contexts and to different degrees. These are very hard problems. And then I've seen some of these hard problems move through taking, sort of like that case study I shared earlier with transformative AI. We learned a lot about operations, which didn't help that company succeed, but it really helped this next company turn something very difficult into a huge success story. One of the things that I've seen out of Australia, for instance, is that you have nationalized databases collecting patient information in which the patients are automatically opted in and have to opt out. Now, this is, from my perspective, very interesting because of the longitudinal data that you can get over decades of someone's life. From a US perspective, AI is much simpler. We have new acts, and I'm happy to share more about that later. But getting patient data and training on it can be very good and very easy, but it's fragmented, and we don't have decades of it because we like to compete rather than cooperate. Whereas I've seen regions in Australia, there are regulations around it, there are rules, there are use cases on how you can use de-identified patient data, but you have much better contextualized, in-depth cases in certain areas that then when you move out of Australia and translate it to other markets, give it a huge edge. When you're speaking with Estonians, you've mentioned the different areas you're working now, and the different research organizations and clusters you're working with now in Estonia. Do you see anything in the collection of, you mentioned AI and unique data sets and unique knowledge products from one region that make a meaningful difference to the other? Or do you see that we're all kind of in the same proverbial boat in figuring out how to make our clinical data meaningful or operationalable in AI?
So we're just starting our journey with Estonia, so I can't say whether we do or we don't. But what I will say is, from what I've seen, as part of the Health Tech Week. I think that Estonia is far ahead, and I think there's a lot to learn. Just to the point before is that, yes, we do collect de-identified patient data. That's often shared and stored at a very national level. And there are certain organisations that have, I suppose, the golden key to that information, but it's very rarely shared. So you often have it, for example, my organisation collects de-identified data from general practice. It's often linked to, and I may mess this up, but the ICD codes, like the coding of the thing, but we don't have any other information. We share that, we analyse that, and we share some of that at a national level, but it is very much de-identified, so it doesn't help. It gives you national statistics, you can do some more analysis, but it doesn't give you what you have in Estonia from what I've seen. And I think that's the gap. And I think that's where there's an opportunity. But the size of Australia versus the size of Estonia, the population, as I said, we're 1.3 million in just my region. It's the same size. So I think it's a very wicked problem, and I'm not sure how to solve it, but I think it has to have a national approach to it. And I do believe that some people in health have also spoken to the Estonian, so I will say it's above my pay grade, some of those questions.
That's how I always feel. So, and these are really hard problems as well, and I don't know that there's a single solution to them. Smitha, I've been very impressed with Singapore and having a strong national leadership into saying, okay, you know what, clusters, you work together, you have some more efforts around transparency, but also just policy setting and dedicating funds with milestones along the way to make sure that the entire country can move meaningfully towards their goals in improving the infrastructure. Can you tell us more about maybe some of the public-private partnerships that you've seen in health innovation and how they're working in Singapore?
Yep, so maybe from the National Health Innovation Center perspective, so we have homegrown innovations that have background IP, and they work with companies to either license it out. Not all innovations are viable as startups. So we have to say no when they're applying for startup grants. So that's one model. The other model is when a company comes to the clinicians or the clinical community with their background IP, with the intention to work with the clinician to co-develop or validate the solution, and also to generate joint foreground IP. So that's another model that we have. So over the years, the public-private partnerships have been emphasized significantly, and economic agencies are highly involved in bringing those companies together as well. But in the last 5 years or so, the healthcare clusters also have their industry engagement offices, or rather their innovation offices have become very mature to deal with that on their own, to bring in technologies as well. So public-private partnerships are really key to commercializing innovations. And Singapore is very much aligned in terms of funding, the strategy, and the policy. And there's always this push from the government as to what we can do better. So in all these years, the key bottleneck we see now is the clinical adoption, and that's what we are working towards. And for the AI part, the government has announced like $200 million of investment into enabling personalized medicine, and also to work on the infrastructure to support these new innovations. And Singapore plans its research, innovation, and enterprise budget in 5-year tranches. And it's usually 1% of the GDP that is invested into these activities. And it's reviewed every 5 years, and new priorities are added accordingly. So in that way, we have a very structured and a mature ecosystem.
I love that it shows the priorities of Singapore, that you have that cadence. That's really lovely. So when you're talking about these sort of relationships, do you see any opportunities for, say, Estonian or international organizations to also, if there's like a clinical alignment or operational alignment, to be a part of those collaborations, or are they only for Singaporean institutes?
No, it's open. So in NHIC specifically, we have an innovation to industry scheme, and any company from anywhere in the world, as long as they find clinical champions in Singapore, can apply for our funding to further develop their product and also validate. So Singapore is a trusted mark among the Asian countries. So we have had many successful cases where it's being co-developed or validated in Singapore, and the VCs have actually taken those technologies. Oh, it's implemented. I mean, it's being implemented in Singapore. Yes, we are ready to take it to the other countries. So we are quite open in that sense. And one of the companies here. So we do have calls for solutions. One of the companies, Estonian companies, is part of one of the. It's part of the final round for the solutions. I think the companies who are shortlisted for those awards, they get support for implementation within the ecosystem.
Oh, that's very important, because that's where you find a lot of capital inefficiency and just getting stuck. That's very interesting. So, we're coming up to the last part of our panel, which is incredibly disappointing, because I find this a very interesting conversation in what common ground we have in trying to actualize so much research and so much innovation, but getting it to the real world clinical situation is always a challenge. Melissa, if you're thinking about everything that you've seen in your work in your region of Australia, your deep experience throughout Australia, and now here in the new Nordics, what is one thing you'd like to leave the audience with when they think about potential collaborations with your research and your institutes there?
I think the one thing that I suppose it's a positive thing or not, but I think that when you do interact with Australia, you have to remember that we are very, very different depending on who you're interacting with and where you are. And as I said, we cover rural, remote, and metro. If you're in Sydney versus Melbourne, it's a very different problem they have, and they have very different solutions. The other part to think about is when we are looking at solutions, the Australian population is very diverse. And we think about our First Nations people who have very different needs to the rest of the other parts of Australia as well. It depends on where you live. We have, towns in the centre of Australia that are thousands of kilometres away from the nearest health service and health system. We have doctors that have to fly in to various areas to provide support. So it's one of the things that if you do interact with Australia, it's not a one-size-fits-all, and we do not have the same population across Australia. We do not have the same population health needs, and it's a thing to do your research and understand the demographic of the area that you would want to be working in. For me personally, I think one of the biggest opportunities is in rural or remote areas, and being able to provide telehealth and those types of support, because that is where we have the biggest challenges from a workforce perspective, particularly in a clinical aspect, because we can't always, nobody wants to go and work in the middle of Australia. There's no shops, there's nothing, you're in the desert. People actually have houses in the ground because it's so hot. No one wants to go and work there. So we have significant workforce challenges, and the only way we can provide healthcare in those areas sometimes is through a telehealth or through somebody that flies in and spends temporary. So just keeping that in mind. And then, as I said, we have slightly different legislation. So that has been my personal experience when we find an amazing solution that we can't necessarily operationalise it or bring it because of the legislation. So just be mindful of that environment.
You know, I do want to emphasize something Melissa mentioned, which is that there's so much opportunity for remote care. So let's say you're from Estonia and you know what temperature should be, and you don't want to live in a house because it gets so hot that's underground. You would do this remotely. So don't be turned off of Australia just because the sand is turning to glass, it gets so hot. I also do want to mention that Australia is a world leader in many areas. She's being very humble, infrastructure and policy aside. They are also the world's leading research foundation into venomous poison vaccines. No one knows why. But all of that aside, seriously, do consider Australia. There's a lot of opportunities there. I think with the data that you have, the infrastructure that you have, and the insights with moving from different regions that you do focus on in here on Australia, there's a lot of opportunity to translate that. A second point very quickly on Melissa's regions. She mentioned that it's not a one-size-fits-all type country. If you want to know really on a specific level what she means about policy changes and demographic changes, look up a time zone map of Australia. I'll leave you with that. It's wild. So, Smitha, thinking about your time here in the new Nordics and the Baltics, throughout Europe, all the different organizations you see that are coming in through your programs to enter Singapore, what's the biggest opportunity do you think your research has for collaboration and innovation that you'd like to make sure the audience is aware of?
Yeah, so I think Estonia and Singapore, we have the same problem for our homegrown startups, that it's a small market. And I mean, scaling up is inevitable for financial sustainability. So we are really looking at setting up cross-border collaborations, but there are several limitations. I mean, Melissa and I were discussing that the data should stay where it is, the money should stay where it is because it's government funded. It cannot be, moved. So I think the key thing is to develop collaboration models where we can do multi-site testing, where each of the entities can fund that specific project, either coming out from Singapore or Estonia, in those jurisdictions. So for me, that's the dream, and it's not easy. The cross-border collaboration, operationalizing it. So that's the dream for me in that sense. And Singapore is a place where there's a very heavy competition for obvious reasons. There's a lot of family offices, VCs have set up their hub there. We have over 400 healthcare startups there, but the resilient ones always make it. Yeah, that's all.
That's wonderful and inspiring. So, do we have any questions from the audience about Australia and Singapore?
And yes, we do have sharks, snakes, and spiders. We have the most deadliest snakes and spiders in the world, before anyone asks that question, because I have been asked that a few times since I've been here.
And we have a lot of humidity. So in spite of that, in spite of all the rain in Tallinn, I still enjoyed the day one.
And I was thinking with our earlier panel on the Middle East, well, I come from the land of sand and oil, so I found my people. So, no, really, come visit us anyway. Okay, do we have any questions? Okay, well, with that said, please do reach out if you think of anything later, and I'd like to give a round of applause for our two lovely guests, 33,000 kilometers to be here today.
Thank you.
Thank you, Elizabeth and panelists. Please, could you stay for a moment here so we can take a picture of you, please?
I want to see me step down and back up again.
In hills.
Thank you.
It's easier to do with everyone watching.
No pressure.
So, before we end the day, there are just a few pointers I would like to say, or key takeaways I would like to say about today. And I think we heard a huge amount of fantastic presentations today, and the discussions were extremely good. I hope you agree. And to me, one of the first things that was already pointed out by our Minister Joller was that when we're talking about data and health data, it's about trust and security. And when we went on and talked about some of the examples of data exchange between countries, it's no surprise that one of the examples that was brought forward was the e-prescription between Finland and Estonia. And we know that in Estonia, at least, let's say, 10, 15 years ago, we had a lot of trust towards our state. And that's the reason we have infrastructure such as Estonian Biobank. And it's probably the same for Finland, as you are now moving even faster with many aspects regarding the European health data space and how the health data is being used. When Michelle pointed out that we actually shouldn't be talking about primary data and secondary data, but the primary use of data and secondary use of data is actually the data is the same, it sort of paints us a matrix where on one axis we have the country change, and on the other hand we have, or on the other axis we have the change from primary to secondary. And from the discussions today, it seems that while the cross-border data exchange is possible and from primary to secondary use is possible, then going from cross-border, cross-use axis or dimension, the difficulty level becomes squared, or maybe even to the power of 3. So how do we work with that? And one of the questions which was raised was, are the regulations a whip? So can we use the regulations to sort of push things forward? And now we know there's a concrete timeline for European health data space. There are significant preparations to comply, and especially implementation and feasibility projects which are ongoing. And from the discussions, it appeared that still doctors and other, I would call them enthusiasts, are taking and covering many roles regarding how the data is made available and how we can get towards this European health data space based stream. So this led me to think that, are we actually able to cover the roles that we need now? And are we able to think forward what types of roles, positions, and jobs we would need if we actually want to implement this huge structure? So in a way, not in any way in a bad way, but still European health data space is a state of mind, it's a mentality. And there are many things that are being already done and which have been done towards that, but still a lot of things have to be done. And one good point Lars mentioned was that how he uses the explanation for the term AI differently when he wants to explain the value that the technology brings. It's not about technology, it's about the value that you would get out of using it. So in this sense, very, very interesting discussions today. I'm also very thankful to Melody for opening up the topic today, to Leon for speaking about the AI Act, and for Elizabeth for the inspirational keynote and leading the last panel. And it was really inspirational to hear about the hunger in the Gulf region and the opportunities that are available there, and get a clear overview what it means to actually get to market there and what type of things you have to consider when going there. Same goes to Australia and Singapore. So we had a very good last panel to discuss the healthcare aspects in these regions. So I'm hoping the day was useful for you. It was quite long. I'm very thankful to all of you who stayed here and as the last people to listen to the whole day. I hope to see you all at least, if not before, then after a year, when we will have the next Estonian Health Tech Week, which includes this conference today, the TTX New Nordics, and also the conference tomorrow is something that you are all invited to. This focuses on the implementation side of AI in the hospitals, and then on Friday in Tallinn, We have we get more insights into US markets, UAE market, and also the German market in healthcare. So thanks. I think you all have deserved a big applause, and it's been a great day. Thank you so much. Oh, right. We are very thankful if you find some time to give us feedback. I'm sure it's not going to be a long and very thorough questionnaire, but as I've been saying to this to a few times already, this is our third time organizing TTX in the Nordics and also Estonian Health Tech Week. So all the feedback is very welcome. We want to do this better, and we want to provide content that is relevant to you. So please take a minute or two and give us some feedback. That's very valuable. Thank you. Yeah, and when you're leaving, I don't have one on me. It's there, but we still need the fabric from the badges. So you can keep the paper tag, but the rest of it we need back.